So I think it's working now. No, it's the one before. It's the one before. So why is palliative care important? One good thing about palliative care that most healthcare professionals do not know is how it improves the quality of the patient, especially when they are referred early. Symptom management is something which is very, which they usually, palliative care patients usually benefit, or anyone enrolled into the palliative care program benefits from. There's enhanced treatment adherence, and family support is also an advantage of being part of a palliative care team. So what are some of the lessons that the association has learned from past HIV programs? One, community mobilization is very, very important, and this is something that past HIV programs have actually used, and it has worked for them, and it's actually improved upon the care that patients received. And then also task shifting and community health workers, using the community health workers and then the task forces to provide the care that is needed. Then multidisciplinary care, which is something that palliative care is all about. And so this has also helped with HIV programs. Then the strong monitoring and evaluation of the programs has also is something that we as an association have seen, and it's a lesson that we've learned to be able to help sustain the palliative care program we intend to strengthen in the country, incorporating HIV programs into it, and then also sustainable financial models. So the Ghana Palliative Care Association has actually presented a 5-year strategic plan to the Ministry of Health, which is currently in progress, and hopefully early next year we are looking at launching this strategic plan. The first pillar of this strategic plan is embedding palliative care into national policy implementation, integrating palliative care into the universal health coverage framework and primary health care, launching dedicated national palliative care work plan for implementation. Then the second is the workforce development and regulation. We are looking at training and certifying the multidisciplinary workforce with palliative care certificates and training. Also, we intend to adopt a competency framework that is going to help a nationwide palliative care program and ensure equitable distribution of palliative care providers. Unfortunately, what we have in Ghana here is a scattered program or scattered service delivery programs where some people are receiving palliative care, and the thing is that majority of those receiving palliative care are those living in the urban areas, showing there is a huge deficiency in palliative care in community in the rural areas. The third pillar is medical and surgical quality system. So the association is looking at introducing a national guideline that is going to look at that would everyone in the country is going to follow when we are providing palliative care. Then strengthening the audit and quality insurance mechanisms within the settings where palliative care will be delivered. And also enhancing continuity of care across facility. So we know that if someone is in the urban area and is moving to the rural area or is moving to the community, we know in Africa we have people moving to the city to receive care. But what happens afterwards when they relocate to their home country or their hometown or their villages is something which we do not follow. So we are looking at a program that is going to ensure there's continuity of care even when they leave us in the tertiary hospitals. Then the fourth pillar, which is home-based and out of facility care. So we are looking more into making sure that everyone receives palliative care even in their communities. But how do we ensure the right thing is done? The association intends to regulate home-based medical care, establish community palliative care models, including the youth groups, and then also expanding digital and telehealth care delivery. Then the fifth one is community engagement and awareness. We all know in Africa, we need to make use of the gatekeepers. We need to make use of those in the community to be able to ensure we have a successful community program. So the association intends to promote acceptance and understanding of the palliative care program. So we are looking at a culturally acceptable palliative care program. Collaborate with the chiefs, faith and traditional leaders, and also spread knowledge through diverse channels. So, innovation from the Ghana Palliative Care Association members. So the association has individual members and then institutional members. So far, this is what we have done. We have hospitals that have palliative care units that are running, most of them, as I said earlier, in the urban areas. We have caregiver certification programs already running. We also have digital home-based services that is being done. Faith health models where we have our spiritual leaders having the opportunity to receive some kind of training and knowledge on palliative care. And then we have some community palliative care integration going on currently. So what we are looking at is what happens. We need to have an aligned healthcare strategy within the country and outside the country. So we are looking at liaising with other African countries to come in. Those who learn, we are learning from them and want them to bring what they have on board to support us. We also look at supporting African health system resilience and then also adaptable to HIV, NCD, and then the primary health care programs. So we are going in to ensure that everyone has access to palliative care per the universal health coverage definition. No one must be left out when we look at palliative care delivery. Everyone that needs palliative care must have access to it. What do we need now as a country, as an association? We need political commitment, sustainable financing, multi-sectoral partnership, technical support for a roll-out. So currently, this is what we are looking at. And in 2026, after our strategic plan is launched, we are going in with collaborating with both local and international sponsors to integrate palliative care fully into the national systems, to leverage HIV lessons to accelerate scale up in palliative care delivery, and also to support the Ghana's model for Africa. I always say that when I'm lecturing, I always tell my students, when you pick something which was actually developed outside the African context, you always have to make it come within your continent, within your context. Even in Africa, we all have different cultures. So within your context, and then make it work. So it's more like adapting and modifying to fit into your system. So that is what we are looking at. So I'm done with my presentation. I'm going to engage my speakers in the conversation. Whatever I've presented, we are going to talk about it and have an in-depth discussion on that. After which, I'll give the floor to the to other audience delegates here to also be able to ask questions and also contribute. And this question I'm going to direct it to the secretary, association secretary, since she's here. Can you tell us more about the strategic plan and how it's going to be beneficial to HIV patients in Ghana? Because currently, there is more like nothing for HIV patients when it comes to palliative care in Ghana. What I know from the team is that they barely even receive referrals from the HIV unit. So it means that our HIV patients are in there, but though they can benefit from palliative care, they are not benefiting from palliative care. So how does the association plan to make sure this particular gap is actually worked on and is closed? We need to close that gap for HIV patients. So how does the association intend to do that?
Okay, thank you very much, and good afternoon again to everyone. So first of all, let me just give a brief rundown of what Ghana Palliative Care Association is. This is a unified body or a mother association of persons who practice palliative care, who have interest in palliative care, or who advocate for palliative care. And we have members throughout the country, like the moderator said. We have institutional members and we have individual members as well. It's been a 30-year journey for the Ghana Palliative Care Association that was initiated somewhere around 1998 by clinical practice in St. Dominic's Hospital at Akritia. And then this very practice was transferred to Koforidua, now called the Matthew 25 House. In the early 2000s, persons like Dr. Mario Paris started the association movement, got it registered and fully integrated into our social welfare and CSO societies in 2005 and 2006. However, the journey has just been like a marking time, stagnant. It's not just pertaining to HIV/AIDS, it is actually through all the disease trajectories in Ghana, and maybe a greater part of sub-Saharan Africa, that we are not really seeing that when we engage palliative care at the beginning of people's diagnosis, it not only improves the quality of life they live, but then it also kind of even increase their life expectancy, and it also helps to cut costs. In Ghana currently, from the last time I counted, which is when the Mahama Cares policy was passed, we have 10 national policies that actually mentions the integration of palliative care. Sadly, it's like a salad dressing. Everybody mixes their own thing and then they pour palliative care just to make it qualify, that policy to qualify as a holistic approach. And that is very wrong, meaning in as much as politicians probably have a little opening that this policy or that policy, including HIV policy, has been passed, and then there is an aspect of palliative care to be integrated, a certain little amount of resources were dedicated to make sure the implementation is done. But here we are, it's at zero. And like I said, it's not just for Ghana. You go around, especially West Africa, it's bad. East Africa has a good story, South Africa has a good story, but in West Africa, it's really bad. We came together about a year and a half ago and decided that it's about time that we push for a standalone policy by ourselves. And by the direction of the Ministry of Health, we are to start with a 5-year strategic plan. And then we can look at the situational analysis after the implementation of this strategic plan, and we can talk about a standalone palliative care policy as a nation. And this is what led to the pillars that Dr. Adewale Asani has spoken about this afternoon. And when you look at the pillars, you realize that they are quite solid. We are mentioning things like medical surgical audits, which doesn't exist in this country. We do M&Ms in hospitals, I mean mortality and morbidity reports. And then we have the clinical meetings where we discuss what went wrong with a particular case or the other, but we don't really do clinical audits. When do we determine there was over-treatment, under-treatment, or probably foresee what the law firms are now terming negligence? We need to see through it before it actually happens. Do we have any systems like that? No, so we don't learn from the lessons. It keeps repeating itself. People have so many complaints about, oh, when my relative was about to die, I was sent to go and then buy a certain medication or that, and then I came back and then the person is gone. I do not understand. Where do you get it addressed? How do we come up with our standard practice guidelines when we do not have a medical audit? So this strategic plan is actually beautiful. It is looking at a space of home-based care and community integration of treatment. Nobody looks at it. It is a great spot because HEFRA takes care of facilities. That is how the act is. Before HEFRA can come in, you should be a facility. But home-based care are not under facilities. So everybody is taking advantage of this great spot and doing whatever they can to help patients and also to harm patients. We are getting a lot of brought-in deaths in the hospital. Do we know what accounts for these deaths and what actually happened in the last days or hours of the persons? No, we are just assuming they are chronically ill, they have HIV/AIDS. It is expected, so they are gone. And then we issue cause of death certificates for them. Even families are learning their lesson that just make sure you cross the 24 hours. So we are there, they bring the patient, make sure that it was good enough to pass the 24-hour test, and then the person passes on. Cool chop. Nobody investigates it. So a lot of things are happening in the homes, and this strategic plan actually looks at it, and we hope that, as promised by the Ministry of Health, it is actually passed by the end of January 2026, so that together with our international communities and anybody that wants to join hands and make sure that this keeps rolling, we can be able to implement some of these things. Because here is a catch: there is no budget cut for palliative care. We just had the last budget 2 weeks ago. Nothing is issued for palliative care, but we must start something so that when there is an established program, now we can also enjoy from what the government will cut for us.
Thank you very much, Mrs. Winifred Otu. My next question, I'm going to draw the next question from what you have just said. And there are two questions. One is going to be about medication. The other one is going to be about what the patient actually experienced from palliative care. Why is HIV not incorporated into the palliative care program currently running at one of the teaching hospitals? Fortunately, we have the pioneers, one of the pioneers, as a speaker here, and I'm going to have her answer the question, what is happening, why that gap for access to palliative care for HIV patients? Why is it that you've been having the program running? I know it's been there since 2012. We had a whole palliative care team. And just across your your institution, the HIV unit is just there. I know how it's just like 2 minutes walk. Even if you are a brisk walker, you can be there in a minute, and it's just across. Why is it that we don't see HIV patients benefiting from palliative care? So, Madam Aisha, kindly answer that question. And then the next question will be going to our pharmacist. Dr. Nkansa. Dr. Nkansa, no, let me leave it so that when you finish, you hand the mic over to her. Dr. Nkansa, we know there's a lot of issue when it comes to pain management. We know what HIV patients go through at home when it comes to pain management. I'm here, I'm talking for HIV because I feel so pathetic when I see at least some people benefiting and HIV is not even enjoying anything. So maybe when Mrs. Aisha Boati is that you could tell us, what are you going to do for us with this new strategic plan? How are you going to improve pain management for our patients?
Okay, thank you, moderator. First of all, as you said, we have the HIV unit just across, just about 2 minutes away from where we have our unit. And before then, palliative was not even accepted in the hospital when it started. People were not really into it. They used to call us the angel of death when they see us coming. So it was not something that anybody wants to do because of the stress that you go through. And most of the times, because they did not understand what is going on, they will only refer when the patient is almost gone. Sometimes you don't even have a meaningful conversation with them. So, and now that we have the public health unit is also dealing with the HIV, and they have the grants and all that, they were not also into it. They did not want to release their patients to us. So we do get some patients, but that is when they have comorbidities, maybe cancer of something, and the person also have HIV in addition. That's when we get the access to that. Or once in a while, the ACE unit will call us that there's somebody there that needs us to come and take care of the pain. Then that's when we get the access to go in and then check for the pain. But apart from that, they were not really into us. And now that the policy is coming, we hope that at least we'll collaborate and then help them, because some of them really need help. Because when they get a neuropathic pain, it's not easy for them. They really struggle, and they do have a lot of they do cry a lot. And so some patients' relatives who have heard about us will come and then say that we are doing self-referral. We want you to come and take care of our patients at home. So then we will go there and then go and take care of the pain and any other mobilities that the person is having. So that's how it is now. But we are praying that things go on well, and at least we do the collaboration and we work together to save our patients from any distressing conditions or symptoms that may happen. Thank you.
Thank you very much,
Madam Aisha.
Madam Moderator. Okay, I think we all know that for morphine use, everybody is careful about that because of the fear, the stigma, and the phobia for morphine. So that still exists, and until we get it down to the training institutions, I believe that we'll still have that problem coming up for that phobia for morphine use. And you know, with the HIV patients, I mean, for the neuropathic pain, chronic neuropathic pain, morphine is not usually the first drug of choice. It would have to be given the gabapentins. But for the severe pain where we are concerned about, that is where you have your morphine coming in. And like Aisha said, most of the time when the patients come in and they're in late stage, that's when they are going to the palliative care unit. They don't start them, you know, most of the time when you are able to get your patients and you know what classes your patients are in, that is when you realize and you discuss whether they will need palliative care so that they can go earlier. Then you can manage them properly. But again, that is a very small unit. With the number of patients that we have, you'd realize that most people are depending more on the cancer patients than even with the HIV because they think they can cope, you know. So you have patients coming in there and you're looking at, we already have the fear, the stigma, the phobia. Then we also have the strict regulations, regulations concerning the procurement and the supply of the morphine. I mean, we need to account for every tablet, everything that we buy that is morphine powder. And you realize that with most patients, we'll be doing more of the liquid preparations for them, which is usually done in the hospital, Kolibu Teaching Hospital, most of the teaching hospitals, and some regional institutions. So as much as possible, we try to procure ourselves, get it at very good prices, so that it can also be affordable for the patients, because at that stage, we don't want them to be going through a lot of costs. So as much as possible, we want to try and get it easily available for the patient, accessible, affordable also for the patients at that stage. And that's where it usually comes in, and we think of what to give to them. But if they are going to go to the community that we are thinking of giving, I think that we have to look at a lot of issues before we can give to the community, because you are sure of them getting it in the hospitals, teaching hospitals, regional hospitals. As soon as they go to the community, you want to be careful of who is dispensing that medication, what dosage is being given to the patient, because if you are not too careful, because of the side effects also of the medication, you might have under treatment also in those areas. And that's what we should be looking at, and be very careful that patients are getting the ideal treatment that they need. So there are a lot of issues we have to look at even as we come out with that strategic plan of how we're going to manage those patients. I believe that they should be managed more where they are in the teaching hospitals before we cascade it down to the community, whereby we might not have the requisite kind of people also managing those patients. So I believe that all this has to be looked at. But again, because of the strict regulatory issues we have, from FDA, it's not something that's easily available and will be really readily available in the community. When we even don't have stocks because maybe we haven't gone through the strict regulatory procedures with FDA, you have to give them feedback on what you procure, on your records, and all those regulatory things are taken into consideration. And you realize that when that is not done in adequate time, sometimes the medications are not available. And when the community is able to get into the country, they are about 10 times more expensive than what you'd have had. They are not affordable for the patients, and that will become a problem even in the community. So I believe that as we roll this out, we have to take all this into consideration and plan well for the patients in the procurement and the supply of the medicines.
Okay, so please don't hand over the mic yet. No, still, I have a follow-up question.
Okay.
On that. So how do you think we will be able to get community, persons in the community, morphine, access to morphine to manage their pain in spite of all these strict Food and Drugs Authority regulations and restrictions?
Okay, so I think that with the patients, we can manage them properly when we plan for them. And issues that have happened over the years, I believe I shall tell you that it's become much, much better now, and you get your morphine easily available than years back. And it all boils down to numbers. When we plan, because we know the number of patients that we are seeing, and you have the physicians also prescribing the medications, then we can plan with them. Then you know that those numbers go into procuring whatever quantity. If I look at Kolibo and I think, for this year, looking at our records and feedback given to FDA, we used only 1 kilo of morphine for the whole year. There's no way FDA is going to give me 2 kilos when I request for it, because I could not even account for the 1 kilo that I bought. So it depends on the society, it depends on our patients. If we have more patients going into palliative care, like Aisha said, and I believe it's also training, and we have the healthcare professionals, we have that number taking care of all of them. I think that will also cascade down to the quantity of medication that we would need, and we would also have to prepare for the number of patients. So it all goes to looking at and planning properly, and I think that shouldn't be a problem. If we're able to account for the quantities that we use, that should not be, then they will be prepared to give us more if we request for that. Thank you.
Thank you very much, Dr. Nkansa. So my question to Dr. Sule. The last time we were in Ho, there was a lot of noise about using innovation, technology to improve access to palliative care. That was somewhere in October. Can you tell us more about that, and also how you intend to use that to support the strategic plan?
All right, good afternoon, good evening. I just hope we are speaking to people and to build a foundation before answering you. You may be here and you will still be wondering, what is palliative care, if I may ask? So what is palliative care? You leave the conference, somebody asks you. There are myriads of definitions, and we pick the most important by WHO, which says that it is an approach that seeks to improve the quality of life of people, and here both children and adults. And this improvement is done through impeccable assessment. In health practice, when we say impeccable assessment, we mean perfect, where your physical assessment is done in such a way that you can establish a differential diagnosis even before a laboratory confirmation. And that the problems that will come out of those assessments, be it physical, social, psychological, spiritual, are addressed to meet the needs of the people or the person you are taking care of. In this regard, we see HIV as also something very far from us, especially if you are not tested positive yet. But what we do know is that sometimes it can be in your system until it kills all the T cells. Then you'll be able to know that you have HIV. So whether we have or not, if you are in this conference, let's bring our minds together and see now we know what palliative care is. What are the innovative measures that we can use to ensure that palliative care addresses the need of patients or individuals with HIV? One, we need what we call telehealth. Telehealth, we know that HIV is mostly associated with stigma and anxiety, depression, etc., etc. So in this case, if you're able to map up the people with those conditions and you hook them into a medium where nobody see them coming to the facility, it will reduce stigma and your ability to get the actual information from them will be done. And the second one is what we call digital health. And in this case, now we have the LIMS, which is in tertiary hospitals. We have your health records. Unlike before in a folder, it can fall down, anybody can read. Now it is only people who have access to the key, password, that have access to your health information, which are prime to your health outcomes. And then the last one we can look at in terms of innovation is AI, which has come to stay. And AI, currently, we can have what we call predictive diagnosis, whereby it will map people who are located in certain areas that have the incidence, and at the end of the day, that predictive analysis can be used to reach up to the individuals that are there. And so that is what we can do in terms of innovation in digital technology to assist individuals that are either having HIV or are likely to have HIV. Thank you so much.
All right, so at this point, I'll just want to give us the opportunity to ask them questions. Is there any question for the speakers? Any clarification on something they have said? Okay. All right. So I'm going to give each one the opportunity. 30 seconds. Just a take-home message for us, and then I'll just wrap up.
Take-home message is that palliative care can be practiced anywhere, and so you should not be limited because of your access to the city. Palliative care is as simple as it can be in your home, and there are techniques to get your family to be able to support you and improve your quality of life when you have any chronic disease, including HIV/AIDS. And that makes it an essential part of care services that we need to be delivering as a country and then as a continent or globally.
All right, just adding to what my able secretary has stated, there are three things I want to leave with all of us. Number one, 30 seconds, yeah. So number one, we should know that palliative care is just a terminology that shouldn't look so big and vague. It simply means helping people with distressing symptoms, difficulties, either HIV, TB, malaria, whichever is the case. we want to assist you to have quality of life. And quality of life in this instance is making you live in a day as if you had thousands of days to have lived. That is the implication. Second, I take a quote from Princess Diana, who once indicated that HIV patients need love and hug just like any other person and should not be seen as people who are harboring contagious diseases. So let's live here with the idea that our speeches, our association, our empathy can bring relief to an HIV person, and that is what palliative care seeks to do. The last one is that in palliative care, we neither hasten nor postpone death. So if it comes, we assist you. If it is not, we make you live as happy as possible. And that is why we have a quotation that says that we start doing what is necessary, and by the time you realize, we are doing what is impossible. God bless you.
Hello. What I also want to leave behind is that I want everybody to embrace it. That's the palliative care. And also, if there are any person who is suffering from any chronic condition or life-limiting illnesses, they should be referred early to the appropriate quarters so that we can also take care of them to give them quality of life. Thank you.
I just want to say that even though there are barriers in using morphine, I believe that if we plan very well for our patients in Ghana, especially those with HIV/AIDS, we'll be able to overcome them.
So beautiful take-home messages from the palliative care group. And we are hoping that very soon the story will be different for HIV patients as we embark on the journey with this 5-year strategic plan. And hopefully in 2028, when we are hosting the next APCA in Ghana, we hope to have the same panel here telling us a different story and telling us how HIV patients are benefiting tremendously from the palliative care program. Thank you very much, speakers. Thank you.